I've got the button, and we should be recording. Let me know if you do not see the record button. Okay, thank you. Thank you. So this session is being recorded now. So what you discuss or share in chat may be part of the recording. If you chat privately to somebody else, that is not captured in the chat record afterwards. And we will send out the recording and the slides to all of the registrants. And we will send them as a PowerPoint slide so that you can use this material if you find it useful rather than sending a PDF of the slides. If you haven't already, go ahead and introduce yourself by typing your name, your role, your organization. And I'd love to hear from everyone on the call, what do you think the biggest telehealth barrier is? What is it? What do you think it is? Hopefully you've already engaged in your own telehealth visit and you could let us know from personal experience. We are offering CME for this session, and we must show this disclosure. And just to confirm that Adrian, Sarah, and I do not have any relevant financial relationships to disclose. Today, even though we have really wordy objectives and we have a title that should reflect what we're going to cover, basically we're going to talk about opportunities to improve where we interface with people and technology. We have an hour and 15 minutes. At our last ECHO session, we were unceremoniously disconnected prematurely. And when we sent out our after session email, we said that we would make up a little bit of what was missed when we got disconnected, because somebody asked a really great question. What is the role of the RN in telehealth? And RN slash, other nursing staff, medical assistants, we need to think about team-based telehealth, and the role of the RN and other members on the care team is really important. We'll have a little bit of a didactic session. We'll have an amazing case presentation from Danielle. If you signed in early, you may have heard us chatting with her, and I think I might need to make a slide with her quote that telehealth is a game changer. And then we would love to have some discussion. And if you have questions along the way, post them into chat. Sarah and Adrian are watching chat. I have just too many things up, even though I have 2 slides, and I can't really see chat very easily. Here is another tip for when you're doing person-centered telehealth. I'm looking at and reading my slide, so I don't have eye contact with you, the audience. The only way I can do that is by looking at the little white light on my computer. And that's not always easy. As humans, we crave seeing what other people's faces look like, what their expressions are. If you are doing telehealth, and if there is the possibility to shift the patient's image so that it is right under the camera, it will look to the patient like you're having good eye contact. It's tough. I do know that some people will take like a little picture and they'll put it right next to the camera so that it looks like when they are talking to someone and they are looking directly into the camera. So our objectives are a little wordy, but we'd like to take a look at a telehealth visit from before the visit, possibly during the visit, maybe a little bit of follow-up. Think about specifically for nurses, how there are some key elements and ways for nurses to optimize the delivery of telehealth services. And hopefully we'll emerge with a list of best practices for telehealth that keep patients safe, result in high quality, and enhance the patient experience and the work life of staff. And then think about telehealth and the impact of shifting to telehealth on how we're doing population health management, particularly in primary care, because we just don't have the same workflows that we've had in place for years and years and years with in-person visits. So I'm going to shift us now to answer that question about RNs and telehealth. This is a document that we put together and sent out after our last ECHO session, and apologies, I'm going to scroll to the meat of the matter. And this first table, table 1, outlines telehealth services and codes where RNs in primary care have a really important role. CMS just released the 2021 Physician Fee Schedule final rule. And in that final rule, they clarify services that are incident to the billing provider. And I think they've needed to do that to ensure people that having RNs and LPNs and MAs participating in the visit is okay. So you can see the service details of a given telehealth service. And then over on the right-hand side are the codes that go with that service and the reimbursement price. So using this information, and those prices are for the state of Utah currently, if you go to the Physician Fee Schedule lookup. So an RN can look and see, what are the ways that they could participate in telehealth visits to enhance reimbursement as well. And if an RN is well versed in telehealth options, they might be able to kind of take over certain ones. And I'll tell you a little more in a second. So we have new and established E&M visits. The RN role can basically be the same as in-person visits, and RNs can actually provide telehealth services to people under the 99211 code. The reimbursement is not huge. I think it's around $22, but it's something, and it's a way to expand access and provide enhanced services to our patients who can't or won't or don't want to or are afraid to come in and see us. I think the next two are humongous opportunities that are missed. One is advanced care planning. If ever there was a time for us to do advanced care planning, now is the time. So can you look at your patients that are 65 and older who have Medicare and start doing outreach to them and do telehealth around advanced care planning? Because somebody may say, I'm DNI, but what if I have COVID? Do I want a ventilator or do I want you to let me go? Like, this is the time to help your patients kind of update those advanced directives and do some advanced care planning. And the reimbursement is pretty darn good. So RNs can provide large portions of the advanced care planning, especially around talking to patients about what advanced care planning is, what advanced directives are, and how to get them done, et cetera. You can see the reimbursement is nothing to sneeze at. Transitional care management, starting in 2020, CMS recognized that there was underutilization of these codes, and so they increased the reimbursement, which is really good. Interestingly, I just looked up the 99496 reimbursement for Alaska, and it's over $300. But for Utah, it's right around $238. And there is a huge role for RNs to get a transitional care management program going and to get the telehealth piece of it going too. There are two codes that you can use for telehealth. Screening and assessment services. This is a peculiar code that I'm not familiar with. Having worked in primary care for many years, the reimbursement is very small, but if there was a bunch of screening and assessments that RNs could administer, that $5 could add up. The initial and subsequent annual wellness visits at our practices that we work with, this is an area that RNs excel at. So they track who's due for the annual wellness visit. They get much of the work done ahead of time before the clinician even pops in to talk to the patients. And the reimbursement, again, is pretty good. So now's the time to use empanelment, identify who's due for annual wellness visits, and let's start doing them by telehealth. And we're checking in with our patients as well, which is really important. So there's chronic kidney disease, patient education. Our RNs are amazing at providing patient education, counseling. I think this one would be one that you'd have to really look into. We did put some resources down below with these to see if an RN wants to dig in and see, how could we kind of leverage this G0296 code, scrolling, sorry. So there are virtual services. The key one is chronic and principal care management. This is just a huge program. It's an echo session of its own, but this is how you get reimbursed for RN and care team time. This is, I don't need to say anymore. It's a huge missed opportunity. Principal care management was possible starting in 2020 and starting in 2021. FQHCs, federally qualified health centers and rural health centers can also do the principal care management. Sorry, scrolling. Behavioral health integration codes, they are very similar to the chronic care management codes. And again, there's a strong role for the RN in getting this going and supporting it. I'm going to scroll again, sorry. Remote physiologic monitoring. This is, an RN could get this whole entire program up and running for a practice. And it is one of the few virtual services that has really excellent data behind it for reducing admissions, readmissions, and emergency department visits. And the rest of the virtual services really require a clinician. So I think that answers the question about what is the RN role in telehealth and virtual services. And there are just so many. All right, so I'm going to move us forward on our didactic content. So when you saw me scrolling, you know, there are a lot of telemedicine options, and we're going to talk today specifically about telehealth, but just remember that in the interface between humans and technology, there's the e-visit, which is online, but most of the others of these primarily have to do with the telephone. It's really telehealth that is tripping people up as they get started. So think about before the telehealth visit, like way before the telehealth visit. How do patients know their options? When was the last time that you went to your organization's website, or you went to your PCP's website? Because hopefully all of us here on this call have a PCP. What happens when you go to your PCP's website? Can you tell whether they do telehealth or don't do telehealth? I had to make an appointment the other day for somebody else, and the provider does not offer telehealth. And I'm just like, oh, really? Got a really high risk person, and they're going to have to go into the office. I tried to look at their website. I actually couldn't find their website, but some practices have really great information on their website. They let patients know what the options are. It's in person-friendly language, sometimes in Spanish as well. And how else do you let patients know what their options are? Have you provided standard scripting to your reception staff? You know, are you letting people know, hey, would you like a telehealth visit? We can get you set up with that. We are finding that it's really important to set expectations with patients, especially our behavioral health specialists. For some reason, when they're having a telehealth visit, they'll call the patient might be walking down the street talking on the phone, or in the middle of shopping, multitasking. I mean, we all do multitasking, but it can be really hard to conduct a telehealth visit when your patient is doing other things and is not, you don't quite have their undivided attention like you do in an exam room. And how do you get the word out? We always say 7 different ways, 7 different times. You know, what works for one person is not going to work for another person. So find different ways to get it out. You can have it on your website. You can have posters in clinic. Having patient partners is an amazing way to supercharge your telehealth, because, for example, remember I was saying, well, you may not have signed on yet, but some patients are reticent to start remote patient monitoring because they're afraid that their data is going to be shared. So if they were to talk to another patient who is doing remote patient monitoring, who is confident in the security of that information, it can be really helpful. Do you have it on your on-hold message? Are your reception staff messaging it? Have you done a text campaign? Have you emailed? Have you sent mail? You know, what are your options for getting the word out? And internally, we've talked about this, how words matter. So we hear a lot that patients need to be educated about telehealth. It has implications that they have knowledge gaps, or, if they're not educated, does that mean they're not smart? So, just thinking, I realize I'm a little extra sensitive to this, but as a clinician, but, I really think the verbiage and the way we approach it is how can we best support patients with telehealth rather than how do we educate them? And it's really important to think about doing outreach through empanelment. So identify who your high-risk patients are and start calling them and let them know you're high risk. If you're delaying care because you're afraid of coming in, we have telehealth. We are working on a project with low and middle income countries. We're working with 6 countries, and it's all about empanelment and outreach in the setting of COVID. And here in the United States, we have empanelment that is far superior to low and middle income countries that can't even generate a list of the patients for which they are responsible. So, the takeaway from this slide, the best practices, make sure patients know what their options are, provide standard scripting for reception staff, make sure patients understand the telehealth expectations, private place to take the call or the video, no multitasking. This is like an in-person visit. Consider your words, of course, and then conduct proactive outreach to high-risk patients. And then, you start going to your medium risk patients. But there are patients in your panel who are unseen and unknown, and they may not be at high risk, but they should also be outreached to let them know about telehealth if they are delaying care. So, we say possession is 9/10 of the law. So for telehealth, possession is really important. So there's a practice that is asking, do you have a smartphone, a tablet, or a desktop computer that has a camera and the internet? And if the patient has one of the 3, they are considered video capable. So we're allowed to do a lot of our telehealth visits without the video part. But for example, the E&M codes, so a level 1, 2, 3, 4, 5 office visit, if you're doing it by telehealth, you're still required to do that by audio and video if it's a Medicare patient. Some state Medicaids allow you to do audio only if you can't do video, but this is the opportunity to start documenting what each patient's capability is. Document it somewhere in the patient chart and demographics on your practice management side. Is there a place to document whether they are video capable? Because if they are not, you have to go to a different option. You have to use just for the public health emergency, the phone only evaluation and management phone call, or you need to use one of those other things that I listed as telemedicine options. This is, in my opinion, a social determinant of health. So telehealth is a great modality for expanding access, keeping people safe, and giving people options. But if you don't have a phone, you don't have the internet, you don't have the data plan, you can't do a telehealth visit. And so if you need care, you have to risk your health to come in to be seen in person at a healthcare organization. It is a social determinant of health. I threw it out as a question, but I would love it if we would consider it. And once you start collecting this information, you can start running measurements, like what % of our patients are video capable? And for those that are not video capable, how can we make them video capable? There are some really creative ways to do that, which we'll touch on in a bit. So possible solutions. So is there a community-based solution to ensure video capability? Some libraries are offering their computers, especially because they're seeing less people come in. So they're offering their computer in a private place for people to do their telehealth visits. Employers are getting more and more savvy about telehealth, and they are providing the audio and the video capability to have a telehealth visit. And you know what? Your employer and your employee is also not going to take time off to go drive, go wait, and then go drive back to work. So it behooves them to provide that video capability. There are some practices that are delivering tablets to patients, and they're even providing on-site support. So using a community health worker and or enlisting other patients and families. And there are other things that I'm sure I haven't even thought of, we haven't even thought of. If you can think of what else we can do for that possession piece, feel free to type it into chat. So, you know, best practices for where we are now is assess and document each patient's video capability, consider access and ability to engage in telehealth as a social determinant of health, and find creative solutions to make sure that patients without a device or connectivity or digital literacy can participate in a telehealth visit. Accommodations, especially for our seniors, we have to consider whether they are hearing or vision impaired, or if they have a cognitive impairment, whether it's related to aging or not. Language and translation needs, limited digital proficiency. I was reading an article from the Harvard Business Review that a clinician said most of my video visits are spent looking at the ceiling, you know. So, you know, you're carrying on a video telehealth visit and it looks like this. So yeah, not all of us spend all our days going from Zoom visit to Zoom visit to Zoom visit and keeping up on email. You know, what are some solutions? Non-clinician caregivers, family members, and it may be platform specific. What I'm hearing from some of the practices that we provide coaching to is that they would love to include patients' family members or other caregivers, but some platforms don't allow it. And we are, as Comanche Health, as a nonprofit quality improvement organization, we are vendor neutral, but I have heard that some practices have switched their platform to Doxy.me because it does accommodate multiple people on the call, as does Zoom Healthcare. Some practices are using healthcare ambassadors who will go to the patient's home and will kind of be there for the telehealth visit. I think a really great idea is so patients are going to have a learning curve with telehealth. And if this is their first telehealth visit, can you make an appointment with a nurse, for example? So this is an ideal opportunity for a nurse to do the practice visit with the patient. It's much lower stakes than during a real visit. And translation services. So Zoom has translation services that are pretty darn good, and I'm not sure whether they charge any extra for it or not, but on our call with our 6 countries, we had somebody from Morocco who only spoke French, and so we were using Zoom, and we had an interpreter so we could understand what he was saying. And you know what, sometimes you just can't make telehealth accommodations and you need to revert to an in-person visit. And then the true spirit of ECHO, I'll teach, I'll learn. If you also have ideas on how to make those accommodations or identify what other barriers are for people, please type it into chat. So the best practice here is know the range of accommodations the patients will need, that your patients will need, and make sure to provide those accommodations whenever needed, whenever you can. I work with a health center whose 40% of their population only speaks Chinese. And so they've had to make some specific modifications around telehealth. So, you know, for those of you that study lean, you know that one of the lean principles is defining value from your customer's perspective. And when it comes to telehealth, there are 2 perspectives. There's the patient's perspective and the staff perspective. And in primary care, we often have a blind eye to our patient's experience. I know this from experience at my practice. When we were doing NCQA recognition, I turned around and asked for our patient satisfaction surveys and found out we hadn't done them in 6 years. You know, what did that say about us? We didn't care what they thought about us. We worked with 29 practices from Harvard, and we gave them an exercise where they had to talk to patients. And they said, how many? We said, okay, fine, 5. And then they said, well, can we have a medical student do it? We said, sure. And then they said, can you give us a form to fill out? So I think that we have opportunities for actually talking to our patients and looking through their eyes. And you may remember that I had a slide with a picture of shoes. So let's walk in other people's shoes to streamline the telehealth process unless we dig in deep and look and think about our opportunities, you just aren't going to find those opportunities to improve. And we always say, map the workflow. Get a couple people in a room who are part of the workflow and map it out. Whether you have stickies on the wall or you're using fancy Visio, map the workflow, confirm it with the people who are doing the work, measure to see whether that process is being followed, and keep improving and measuring and improving and measuring. It is one of the key mantras of primary care: measure, improve, measure. The other one around quality improvement is thou shalt not decrease clinic productivity, but that's for another day. So is the care team optimized for telehealth? What I'm finding is that no, that's not happening. So we're not doing pre-visit planning, we're not huddling. How do you make sure that these things happen? Because when they're not happening, you're becoming inefficient. You're putting your patients at risk for missed and delayed diagnoses, and the quality is going down. There are a lot of people now studying what is the quality of a telehealth visit. And if we don't demonstrate it, our payers are going to stop paying us the same rate for an in-person visit with telehealth. And how do we know what can be better? Get feedback, get lots of feedback. It is one of the keys to building expertise. There's even a book about it. So make it easy. So I talked to some practices, and their way of getting feedback from patients is to mail the CAPS survey. So, that doesn't work. The patient, that's not immediate. You have selection bias, only those who are motivated to send that survey back. Like, just make it easy for the patient. And we have them in our sites. At the end of a telehealth visit, just ask, how was your visit? What could we have done better? Collect a lot of it. I have one practice that is really crafty, and they collect about 250 surveys per month. They've made it easy for their patient. Do it immediately, act on it. So the other thing I see is the practices get feedback from their patients, and then they don't do anything about it. So, why are you even collecting it? Circle back. If somebody has a great idea, let them know. Or if somebody had a horrible experience, let them know, I'm so sorry that happened. We're going to fix it. And make sure that if you make a change, that it results in improvement, and you'll know that by measurement, of course. And then hardwire the change. We all have a hard time changing, and there are strategies to hardwire changes. And that is also an echo session for another day, maybe. Think about what we need to be prepared for before we start that telehealth visit. So what is needed for telehealth? Do we need to have accommodations? Does the patient have possession? Does the patient have proficiency? Have they attended a telehealth visit before? Because if they have not, this could be a rough one, and we need to be prepared for it. Maybe the clinician needs extra time, or maybe the nurse starts the visit and gets all the kinks worked out, and the clinician can be right there at hand. And as soon as the team and the patient are ready, the clinician then actually starts their portion of the telehealth visit. But I will say that we should be adhering our team-based care principles, and we should not have our clinicians doing things that you don't need a medical license to do, because we're still in a fee-for-service world. And so the more telehealth visits that they can run through, the better able we are to keep the lights on and pay people and keep people employed. No preventive and chronic care gaps. How we used to do that in person. So if your process previously was you're using NextGen and you have your ITI reports and it prints out who's due for what, how are you going to translate that to the virtual world? Do you have access to the patient chart? Do you have the health maintenance module? Hopefully it's accurate because you've been having good workflows previously to let you know who's due for what and address what is due and how it's going to get done and what's the plan for deferred services. So for example, with colorectal cancer screening, if somebody is due, we may mail them a fit card. If the patient says, yeah, I don't have a post office box, or for whatever reason, a service needs to be deferred, you need to document it in the chart. This is a patient safety issue. If we let slide preventive and chronic care gaps, identifying them and addressing them. We can't close them because closing them is usually up to the patients, but we can identify where those gaps are and we can address it. If you don't document that you've done that and have a plan for deferred services, we could have missed and delayed diagnoses. We already are having missed and delayed diagnoses with telehealth. And it is terrible for patients and it's terrible for clinicians because that is the #1 reason for malpractice settlements is missed and delayed diagnoses. And I am just honestly a little bit terrified that we are not optimizing our techno-human interfaces and workflows to make sure that we're keeping patients safe. They need information on copay or out-of-pocket expenses, especially in the state of Utah. So if you're doing a telehealth visit and it is for a Utah Medicaid patient, the consent that Utah requires that the patient understand their copay and out-of-pocket expenses. And as a clinician, you know, clinicians don't learn a lot about practice management as part of their schooling. And so when a patient asks us, well, how much is this going to pay? How much is this going to cost me? We just kind of like shake our head and go, I don't know. It's not, you know, I don't do that. That's no longer acceptable. And we can look at ahead of time. What insurance does the patient have? Do they have Medicare? Are they going to have to pay a 20% copay, or is it waived as it should be during the public health emergency? But we should not ignore that elephant in the room and have cost transparency for our patients. And honestly, in the state of Utah, Utah Medicaid requires it. Again, I say, what else? You know, what are we missing? I will say that at this point, our takeaway best practices are make sure that each care team member has the information needed before the televisit. And don't forget about identifying and addressing chronic and preventive gaps in care and letting the patients know their out-of-pocket expenses. And in Utah Medicaid for consent even requires that you tell the patient how they're going to pay that. So we need to get with the program on that one. So checklist. And this checklist is, I'm sure, woefully inadequate. But once you have the televisit going, make sure patients can tell who is on the video. You know, even if you have to have a big sign behind you saying, Trudy Bearden, physician assistant, make sure they know. If you have your ID badge and it looks like, you know, 3 font to the patient on the video, that's not helpful. It needs to be in a way that patients can understand exactly who they are talking to. Are they talking to a physician? Are they talking to a medical assistant? Make that abundantly clear, just like you do in the in-person setting. Identify who you are, introduce yourself. Hi, I'm Trudy Bearden. I'm your physician assistant. I'll be seeing you today. Welcome to our telehealth visit. Consent is going to be required. So for Medicare, and this is a nurse can obtain and document consent. In the final rule that was just published a few days ago, CMS made clear that auxiliary staff can obtain and document that consent. So there's Medicare consent, which is really super duper easy. They just consent to the telehealth visit. You let them know about any copays, that's fine. For Utah Medicaid, it's like incredibly complex. You know, who's going to document? How are you going to document it? Sometimes some practices will do it by paper. They'll mail it to the patient. The patient has to send it back. They get it scanned into the chart ahead of time. But you can do verbal consent as long as you document it in the chart. Documentation. So we have a Patient and Family Advisory Council, and they have told us that when clinicians are looking at the other screen like this, and they're documenting in the EHR, patients feel much better if you just tell them, you know, I'm really sorry that I don't have eye contact with you, but I have this other screen over here and I need to type in some notes. And otherwise they're like, what is he checking email over there? Like, what am I, chopped liver? So, you know, thinking about what the perception is to the patient and tell them what you're doing, because they can't see where your hands are, where your eyes are, where that other screen is. So just make sure you tell them, or have a scribe the eye contact and paying close attention to your patient is even more important on a telehealth visit. So can you have somebody who can scribe? And nurses make excellent scribes. They're sometimes, I think, even better than the clinicians. So this is a key role for nurses on the day of the telehealth visit. Camera, make sure you have your camera placed in the right place. We talked about how you can have eye contact, like put a little, I don't know, smiley face by where your camera is. So you're actually talking to your patient rather than, you know, reading your slide or you're looking at the EHR or looking off somewhere else because their picture is down at the lower right-hand corner on your other screen. And so you think you're looking at your patient, but your patient doesn't see you looking at them. They see you looking away. So you have to really focus on that camera. And it is hard for some people to do. I know from personal experience, it's hard for me to kind of look at that little white dot and connect to that little white dot when I really want to be looking at your picture wherever it is on my screen. I can move that so that it's a little closer to the camera, but just think about camera. And I already covered that one of our patient advisors gave us that pro tip that if you're not looking at them or engaging with them on the televisit, just let them know, let the patient know. Background, what is the patient seeing and hearing? I'm a practice coach, and so I'm on calls with a lot of people at a lot of healthcare organizations, and a lot of times they're right there in clinic, and there's so much noise, I can barely hear the person to whom I'm speaking. So when the patient calls, you know, do you have good sound quality? Are you in a quiet place? It's really important. And what does the patient see? You know, if you're working from home, are they seeing your unmade bed in the background? Or are you all professional and have a nice bookcase with to show what a good reader you are? You know, just kind of, again, walk in their shoes and see through their eyes. You know, have some sort of a professional background if you possibly can. The Zoom backgrounds are great for if you don't want somebody to see, you know, that you still have dirty dishes in the background or you haven't made your bed, but it's really distracting because there's this shadow around you. And if you talk with your hands like I do, which I know can be a little bit annoying, but I can't help myself. When you're doing this with a fake background, your arm disappears and gets discombobulated. And I'm not sure that that's the best experience for patients. If you have to do that, then you have to do that. Make sure that the sound check is good for both parties. So if I'm talking and cutting out or the patient is cutting out, that's not a high quality visit. Understand whether you have a stable connection, whether the patient has a good connection. And at the start of the visit, let the patient know what the backup plan is. Like, just tell them, look, if we lose internet, or, you know, things are garbled or the video is glitchy, I'm just going to hang up and call you on the phone, okay? So let me just double check what your phone number is. Make sure you have on-hand support and a plan for techno problems. There's nothing worse than trying to do a televisit with a patient and, you know, you've got technical issues. And acknowledge when other people speak. I think what we do with patients a lot is they'll say something and we just go on to our next question. And so it's important to say, oh, thank you. You know, that's really helpful information. And that's actually a good practice no matter what virtual meeting you're in. When people talk, whether you're on a phone call or in a meeting and you're on a Zoom call and somebody says something and you just go on to the next thing, the other person feels very unheard. So acknowledge when your patient speaks. So I'm looking at the time and I want to be sure that we have enough time for Danielle because I think we're going to learn a lot from her. And just kind of a double check on our best practices. We'll send out kind of these best practices that I say, oh, and here we have these best practices. In our follow-up email to all of you, we will send what all those best practices are. And I can't see chat, but if there are best practices in there, we will capture those. So find a way to identify each member on the team so the patient is clear on who's who. Assign obtaining and documenting consent to a team member and have a standard process. Make documenting the visit as easy as possible. Use a scribe, provide 2 screens, etc. It's really hard for a provider to have the screen taken up by the patient, but then also have to document if you only have 1 screen. I honestly don't know how you would do it unless you like split your screen. Make sure both the clinician and the patient or family are in quiet areas. Check sound for both parties, so to speak, clarify with everyone what the backup plan is, have support on hand, and acknowledge when other people make contributions. So we are about 25 minutes in. See if I can do a time check. All right. And I think what I'd like to do is turn things over to Danielle now. And if we have time, we'll talk about the other pieces of information. And I'm going to do a slide scroll. So apologies, because it's going to be really quick. But if we have time, we will return to quality improvement and measurement because it's really important. We'll talk about quality assurance. We'll kind of reframe what the takeaways are for today. And then I'd really like to check in to make sure that we hit the mark versus a colossal miss. So thus far, we've filled in the gaps. We've covered the didactic portion, and I am most excited to get to our case presentation because hearing from people who are on the field actually doing telehealth is the best. So Sarah, I'm going to turn it over to you.
And we're really happy today to have Danielle with us. They're having quite a few COVID cases where her clinic is, and I know that she's very busy. She was actually even on the news last night. We appreciate her taking time, and we appreciate Amber's time, the RN that works in our clinic, and that they've been willing to come and share some of their experiences with us. Danielle's a nurse practitioner that has her own clinic called Eastern Utah Women's Health, and I'll let her tell you a little bit more about it. Danielle, I'll turn it over to you.
Hi, thank you so much for having us. Amber and I are practicing what we preach, so we've got our masks on. So if we sound a little garbled, that's why. So our clinic, I was the first woman and first nurse practitioner to own and operate a women's health clinic in Carbon, Emery, and Grand counties. And so we were so fortunate that we partnered early on with behavioral health and became the first integrated physical and behavioral health clinic in the state of Utah. And then the other counties have kind of modeled after what we've done. So it's just been a wonderful experience, and all the partnerships with the community and everything like that. So we thought about telehealth really early. We were trying to increase access to care to women who could not get to us. And so telehealth has always been on our radar. It was just figuring out how to bill for it, how to actually do it, get around all the rules and regs. But now since COVID this is like a dream come true. So I embraced it with open arms. I'm like, this is really the way in which healthcare is going in the future. So some comments on what Trudy was saying is we have a texting app that's HIPAA compliant. And so we text reminders to our patients, like your colonoscopies do, your mammograms do, your well woman visits do, all of that. And then we also we've created forms that we can text and they can fill out, like consent forms or COVID screening forms or anything like that they can fill out from their phone, any device, or a computer. So that has really helped that technological end of it. So we're here to maybe help get some advice from you guys on how we can do things a little bit better. So if you want to go ahead and advance the slide, we'll tell you what we're working on. So we're located in Price, Utah. We do cover Carbon, Emery, and Grand counties. So we offer comprehensive women's health and primary care services. And I don't even think behavioral health anymore because that's just part of primary care and women's health services. So that's also included. Okay, next slide. So we have two situations that we're trying to get help with. Patients do not want to use their cameras during telehealth visits. They don't want to be seen on camera. And that goes for some members of our staff as well. We chose part of our texting app, they had a telehealth app where you can just text the link and you could access it from any device. So you don't have to upload anything. You don't have to download Zoom. You don't have to have any special equipment. No matter where you're at and what you're using, you just click on it and it comes up. So it should be fairly easy, right? But many still prefer talking on the phone, and we need to transition that so that we can get out of the relief package and get right into what we need to do. The second situation we'd like some help with today is collecting the copay. So because I run the practice, I have no problem like telling them, oh, it looks like your copay is $20 according to your health insurance, or this test that you're going to get, this lab test will run you anywhere between $25 and $35, depending on where you go. A diagnostic mammogram is in this ballpark. Here are the different places you can get it. I feel comfortable talking to them about it because it's so much of running a practice for me. What I'm not comfortable with and what Amber's not comfortable with is collecting the copay. How do we get the money in our pockets? We used to only send out about 30 statements, and we're at 100 now for uncollected copays and things like that. So we really could use some help in that area. Okay, next slide. So situation number one, we are known for our warmth, our caring, that come in and sit down and just let us snuggle you up, make you feel comfortable kind of feeling. And that's a bigger challenge for us when people don't want to use their cameras. We can't get a read on body language. They may not feel as connected because we're not looking at one another. We're not doing, well, I talk with my hands too, Trudy. We're not doing all the hand gestures that they're used to my Italian heritage doing in front of them. So that's really hard to do. And then for situation number two, collecting the copays, is prior to telehealth, like it was pretty streamlined. They walk in the door, Vicki greets them. She's the first point of contact. She's very warm and welcoming and makes sure everything's filled out and then collects the copay, right? Done. Well, since telehealth, Amber's our first point of contact, and she gathers the information and either hands off to me or she does her own visit. So we don't know where to get that copay. So part of our texting app as well will text them, your copay is $40. Please click this button and pay it. And they can pay it directly from their phone. But we're still not collecting that. So go ahead and advance the slide. So I guess the core issue for both situations, as we were going through it and talking about what we need to do, we've not really figured out how to use our waiting room. And we're not really sure like if other people other than the patient can be on the call or whatever. But my question to you guys, is that too many transfers? So like Vicki gets them on the phone, welcomes them, makes sure everything's up to date, collects their copay, and then transfers to Amber. Amber gathers their information. Amber transfers to me. Then we transfer them back to Vicki to make a follow-up appointment. I don't know how well that flows. And we've also entertained the idea of, you know, can Vicki collect the copay the day before? But is that kosher? Like, do you really pay for something before you even experience it? What if you don't show? I just would like to get an idea of like what you guys think about it and how that feels. And then how does Vicki do all of that where she's managing everything that way and still answering calls? So as a little bit of background as well. So we're not always necessarily working in the clinic because half of us have had to be quarantined for exposures and everything else. So we are really working from home a lot. So we're all in different areas. So it's not like I can run up to the front desk and say, hey, hop on my Zoom call and grab her money and then we're out. It just feels weird, if that makes any sense. Okay, so next slide. And just recommendations. How have you all increased the uptake of camera use? Which Trudy, you did a great job. That was great. And then how do you convey warmth and connection with patients who don't want to use their camera? Like, how do you do that over the phone? And then what is your process for collecting copays now that the nurse is the first point of contact?
Well, you have some great questions, Danielle. You do have we do have one comment from Dr. Cherie Brunker. Sometimes I have a call with a patient when I suggest a later video visit. I describe it as a face-to-face visit, like when you are in a clinic, and that it helps with communication. For a brief visit, I've used FaceTime some and just said, okay, I'll call you and you answer and we'll be on together. My patient said, wow, that was easy. Be sure to call me like that next time. So I just wanted to let you know. Oh, she also says, I have a VV, I'm not sure what that is, with my doctor today. When I scheduled it online, I was asked to pay my copay and that I wouldn't be charged until after the visit. So I think we all get more used to change in procedures.
Oh, that's a really good idea for sure.
So I want to let the group, you can unmute yourself and make comments and let Danielle know what you've done.
Excuse me. I'm alone. Hi. Thank you. Hi, Zoe Robbins here. I was just thinking, as you were saying, how do you, encourage people to pay and things? In the world of substance abuse treatment, sometimes we use what are called motivational incentives. So if a patient comes in to get their UA or something, you might have a gift card or something that to you is minimal value. It's much more valuable to have a bill paid on time than give away a $5 thing. But it's motivational. People just love to get something for giving something. And I wonder if that's sort of an interesting idea. Pay your bill in full today and, put your name in a hat or something,
That's a really good idea.
It is.
Yeah,
Dr. Brunker, I wonder if you might be willing to unmute and talk a little bit more about what you entered. Maybe she will in a minute. Anyone else?
Can I just say one thing to Zoe? Zoe, Connie Kitchens just sent us an invite to meet each other. So wonderful to meet each other. And thank you for the great comment.
Yeah, likewise, I've been hearing your name too. I look forward to continuing post Echo.
Right, that's awesome.
Trudy, is that you ringing the bell?
That is not. I don't know where that came from. It would be great to hear a little more from Dr. Brunker about strategies.
I think
maybe she's having a hard time coming off of mute.
Yeah. Anyone else?
And I can't unmute her.
Oh, she's actually working in a patient admission, so she cannot come off
Okay.
mute.
Okay.
That's multitasking.
Whoa. Whoa. Danielle,
I'm
I wonder.
I've done that before.
Danielle, have you thought about asking your patients for feedback about the transitions? It does sound as though the transitions follow an in-person visit, and at least you're not hanging up on them in between. So I work with a practice that first the receptionist calls and gets some information and then hangs up, and then the MA calls and does intake and then hangs up, and then the clinician calls. So it's kind of like, you know, when should I expect my clinician to actually call me? And patients don't like it at all. So.
Yeah, we actually purchased a little add-on to one of our programs so that we could, because it's not accessible here in rural America, where we use a phone system so that we can transfer to each other from our homes and from our computers so that we're not disconnecting with our patients. Now, to get that to work as part as telehealth, we need to learn a little bit more about that. Now, you said that multiple people can be on like a DoxyMe call, but is that multiple transfers or is that just multiple people all at one time?
You're muted, Trudy.
Multiple people all at one time. So one of the things that we heard from our patient and family advisor council, which they then brought forward to NCQA, and the response was, why didn't we think about that, was having a caregiver join. So, you know, as a clinician, you often have somebody who has cognitive impairment and they leave, and, you know, you kind of wonder, does that get transferred to their primary caregiver at home? So what if you could have that caregiver on the line? And we're also thinking about how to incorporate family, loved ones, caregivers, other clinicians involved in a patient's care, also in the nursing setting, so long-term care facilities. So now is like an amazing opportunity. So you might have somebody who is in North Carolina, you know, mom may be in Utah, and so being able to join that call, I mean, you have to be careful. So it has to be the health proxy or the patient has to give permission for that. But I think it's a huge opportunity that, you know, we don't think about necessarily.
I agree.
But you could do it with staff too, like, yeah.
But you could do it with staff too. So like the whole staff would join the call and then we would listen to Vicky do her spill and collect, and then she would go off. But then I would be listening to Amber's, like it's duplicative work, kind of. Yeah, then I can't finish up with my other patient because I'm listening to Amber on the call. So the flow wouldn't go that way. But I do like that caregivers and like family and everything can join in. And I would like to see faces on that. I think that would be wonderful. In women's health, we do that all the time because there's always somebody concerned about something else. We get permission from the patient, whether it's a phone call or a FaceTime. When we were in clinic, we did it all the time. But to do it and to see people and see their reactions and their interactions, that would be extremely helpful. So I guess we don't really know of a telehealth where you can transfer, right?
You know,
Does anybody?
Danielle, I don't, and I'll let other people comment, but I do want to tell you about something I just heard on IHI. Now, this will only work if you're working in your clinic. But one of the things that they're doing is they actually have a tablet and they sit it on the exam table. And then the caregivers actually go in and out of the room just as they would if they were in a normal clinic visit. You have to coordinate that because you don't want the patient sitting there waiting. But, you know, obviously this doesn't work if you're not in the clinic setting, but if you are, that's one of the fixes that we heard about on the IHI conference.
That's brilliant. That is definitely brilliant. If you're in clinic, that's amazing.
Danielle, what platform are you using?
So we are currently using, so we have Next Gen Office, and they have a real crappy telehealth
Friday.
portion
Thank you.
of that. It's not that amazing. So we are now, so we use Solution Reach. So it was, I don't know if you've heard of it, but it was created for dentists, because dentists have been texting and reminding and doing all that sort of stuff years and years ago. And so we liked it because all of the majority of our clients like to text. And so it was a texting option that we can do. And then they just had a very inexpensive add-on for telehealth, which, you know, kind of shows because we haven't really figured it out just yet on how to go back and forth or use waiting rooms and things. So that's what we're using right now. Was there something in the comments?
Yes, there is. In our clinics, once the patient is scheduled for their video, and this is from Colleen, for their video visit, they can complete e-check-in 24 to 48 hours prior to their visit, as well as pay their copay. The day of the appointment, the front desk just verifies all appointments have completed e-check-in on the schedule. The medical assistant will then call the patient at least an hour prior to the appointment time to complete rooming process. Once completed, the patient is advised to be ready for their visit 10 minutes prior to appointment time, meaning they should be on video visit. So when the provider is ready to launch the visit, they use Epic. Boy, that's a great system.
That is actually amazing. So that is actually the ideal setup. Here's the thing. So we send, so the e-check-in is usually due in the portal, in our patient portal. We probably need to do a campaign for uptake for the patient portal so that people can get in and do that. And they can pay their bill from there and everything. It's just been really hard to get patients to actually utilize that. My chart patient portal is very easy to use. Okay, that's good. I'll let Sarah read the comments in the comment section, but yeah, so I think that would kill like all birds with one stone, right? Is to be able to have them check in and do that way.
Yeah, Colleen just agreed with you that it's very difficult to get patient buy-in. And Catherine said, as a continuation to Colleen's comment, I have been on the patient end of this system and found it very user-friendly.
Very user-friendly. Great. Okay. Well, that was wonderful. Thank you.
Danielle, one thought about patient portal uptake. The biggest motivator for patient portal use I've seen is when clinicians themselves promote it, and also kind of promoting the other things about the portal, especially for results. So if you, the clinician, say you can get your results as soon as I've reviewed them, I post them to the portal, and you can have access to your results. I remember, I don't know, more years than I care to say, working with a practice. They actually had eClinicalWorks, and I talked to them about the portal. They got the portal going. I came back, and one of the physicians said it's cut down on my phone calls by 40%. But they couldn't get the portal going. I mean, they even had campaigns. They like gave staff $5 for every 5 emails that they signed up for the portal. But it was truly when the clinicians started messaging it in the exam rooms, which, you know, now I don't have so many of those exam rooms, but hearing it from you and everything that they can do in the portal, sometimes actually taking a minute to walk them through the portal so that kind of it's one of, you know, we say 7 times, 7 different ways. Having somebody kind of hold their hand to walk through that can be helpful as well. So it's one of those things. A lot of people say our patients don't check the portal, people don't have email addresses, and actually the data suggests otherwise. So good luck with that. I hope it works out well for you, because it can be great for the patients that want that access. It doesn't work for everyone, but for the people who like it, they love it.
Trudy, thank you so much for that suggestion. So our system just updated because we would have to go to the practice management portion to be able to send them a portal request, everything else. So now it just went over to the EHR to where I can, instead of Vicky have to send them that invite again, I can send that invite. So knowing that it comes from the clinician, like that's 3 minutes of my time to say, hey, I'm going to send you this invite. If you just want to click on your email, I'll walk you through it. And then that way you'll get everything and be able to communicate a lot quicker. I think just that little nugget of information is going to make a big difference. Thank you for that. Thank you.
Great. We're glad to hear that, Danielle. Any other comments? Any other help for Danielle? Colleen said we seem to get more patient buy-in when providers encourage our patients to utilize the system. It's a direct link to their provider.
I will promote that. I can do that.
And just one other piece of information, Trudy mentioned the translation services on Zoom. I don't know if any of you are even using Zoom at this point. I think most of you have switched to medical record systems, but I did check the price. It's 10 cents per word, which sounds expensive, but it's actually not. I calculated it. If you have like 4,000 words in the conversation, it's only $40. So compared to what I used to pay in the hospital for translation services, I can tell you that's pretty reasonable. Trudy, I'm going to turn it back to you.
All right. Thank you for looking that up. That's great information to have. You know, and Zoom, there's Zoom that we're using today, but there's also Zoom Healthcare, which is HIPAA compliant. So I think really it's a learning curve. So once patients learn whatever system it is that you have, they will start using it a little bit more. So let's, are there any other comments or questions on the line about telehealth and how we can streamline the process and make it as easy as possible? I work with one health center and they were using the telephone E&M code. So they were calling patients. They are a health center, so they get reimbursed the same whether they do the telephone E&M code or they do telehealth. And they were doing the telephone E&M and their no-show rate was 2%. Awesome. Like, I mean, that was down from like 30% for their in-person visits. But then they shifted to, we're going to really do real telehealth with the audio and the visual. And so they started sending that link and their no-show rate dropped down to 50%. You know, patients vote with their feet. It wasn't working for them anymore. And I know that the telephone E&M code is really great, but it's going to go away after the public health emergency. And the final rule, CMS did kind of, they added, there was a lot of pressure from people, response to the proposed rule saying we need to have a telephone option for E&M. So they did expand some codes, but it's really around the virtual communication services. It's not as easy as that telephone E&M call. So, you know, it's not the easiest for patients. And I think we're seeing inequity in alarming ways with telehealth, which is unfortunate. There's not much we can do about that. There are some things, and we have to be creative, but it does require time and money and warm bodies. So it's a little bit difficult. So I would love to do a poll. I would love to cover that other slide. But honestly, I did a time check and we're bumping up to our hour and 15 minutes. And I think the most important piece was that we had a great conversation. Danielle, thank you so much. I think that was the best part of today's session, was hearing from you and from everyone else who had input. So I want to thank everyone, and we're just going to close this session. Have a really great rest of the week. I look forward to our next session.
Trudy, can I just make one quick announcement that we do have an echo series for long-term care coming up in the spring, talking about telehealth from more of the long-term care setting. So I just wanted to make sure that people are aware of that, and I am putting the link to register in our chat. There's also a link to please complete a very brief evaluation survey. If you could please complete that survey before you wrap up today, and then just a quick note about the upcoming long-term care telehealth echo series starting in February. Thanks.
Thank you, Adrian. And thank you all for
Thank you so
joining
much,
us
Adrian.
today.
Bye-bye.